When blood pressure falls and organ fails, yes, it is shock. Let us understand shock in today's video. Let us define shock. Why shock feels. Shock is a state of severe impairment of tissue perfusion that, if prolonged, leads to the cellular injury or multi-organ dysfunction or death. It says the severe impairment of the tissue where inadequate oxygen is delivered, it leads to the shock. Shock is not defined by blood pressure alone. The central problem is inadequate oxygen supply to meet the metabolic demands of the body. Without prompt recognition and correction, cells shift to anaerobic metabolism, lactic acid accumulates, and irreversible organ damage occurs within hours. The key insight is early recognition prevents irreversible damage and death. Every minute of delay worsens the prognosis in the shock conditions. The core pathophysiology behind the shock is the oxygen delivery failure. All forms of shock converge on single catastrophic endpoint, that is, failure of oxygen to the body where it meets the cellular metabolic demands. Understanding this cascade is essential for rational and targeted management, where cellular hypoxia occurs leading to the inadequate perfusion. It leads to the anaerobic metabolism and it leads to the cell death and organ failure. Where the cellular hypoxia, oxygen supply fails to meet the cellular demand of the body, inadequate perfusion where the reduced cardiac output or impaired distribution occurs. Anaerobic metabolism where the lactic acid rises and metabolic acidosis develops. In cell death and the organ failure, irreversible damage occurs which cannot be corrected. The hemodynamic imbalance manifests reduced cardiac output and the impaired perfusion pressure. The body initially compensates via sympathetic activation, that is the tachycardia, vasoconstriction, but these mechanisms eventually fail, leading to the progressive decompensation and multi-organ failure. Types of shock. The shock is classified as distributive shock, cardiogenic shock, obstructive shock, and hypovolemic shock. In distributive shock, the shock can be caused by sepsis, anaphylaxis, neurogenic, endocrine, or pancreatitis. In cardiogenic, it can be myopathic, arrhythmic, or mechanical. In obstructive, it can be due to the tension, pneumothorax, massive pulmonary effusion, pericardial tamponade. In hypovolemic shock, it can be due to the hemorrhagic or the fluid loss. Shock isn't only hypotension. The bedside pattern recognition, where the classical clinical features are altered mental status of the patient, where the patient feels restless, confusion, and cerebral hyperperfusion occurs. Second is the oliguria, where the urine output is less than 0.5 ml per kg per hour, is the early marker for renal hypoperfusion. Third is the cold and clammy skin, where the peripheral vasoconstriction, except in distributive shock, warm extremities. The last is the metabolic acidosis, where the elevated lactate from the anaerobic metabolism, it leads to the metabolic acidosis. Don't wait for hypotension to diagnose the shock. Look for the signs of hypoperfusion first, like the oliguria, cold clammy skin, and start the treatment. The critical insight is the hypotension is a late sign. Inadequate tissue perfusion and organ dysfunction may present with normal blood pressure in early shock, especially in young and healthy adults with strong compensatory mechanisms. Stages of shock. Shock follows a predictable clinical trajectory. Recognizing the stage determines the urgency of intervention and treatment guidelines. Stage 1 is the compensated or pre-shock, where the perfusion is worsening but Overt hypotension may be absent. Sympathetic compensation maintains the BP. Tachycardia, peripheral vasoconstriction, mild tachypnea can occur. This is the window of opportunity to treat the patient. Second is the stage of progressive stage where the compensatory mechanism fails, worsening the metabolic acidosis, significant hypoperfusion like renal, hepatic, cerebral, rising the lactate, oliguria, altered consciousness, hemodynamic instability becomes evident. The third stage is refractory or irreversible stage of shock where the cellular death is widespread. Multi-organ dysfunction syndrome develops, vasopressor fails to maintain the perfusion. Mortality is high. Prevention through early recognition is paramount. Let us see the investigation strategy for the shock. To confirm the hypotension, we have serum lactate where the more than 2 millimoles per liter indicates the anaerobic metabolism and more than 4 it indicates severe shock. Second, we have the ABG where metabolic acidosis can be detected. Next, we have the urine output where the oliguria is the first sign for the hypoperfusion or the renal signs of hypoperfusion. Next, we have the mixed venous O2 where the low mixed venous O2 indicates inadequate oxygen delivery to the body. To identify the etiology, ECG plus troponin, it can rule out the cause like acute MI or arrhythmia. Echocardiography is done for the tamponade, valve pathology and RV strain. Complete blood count where the hemoglobin, WBC, platelets, chest X-ray for pneumothorax, pneumonia, intra-abdominal catastrophe. Diagnosis. The diagnostic approach in shock follows two-step logic. First, identify the primary physiological disturbance, then determine the specific cause within the category. Treatment must begin immediately. Don't wait for full confirmation. In pump failure, cardiogenic shock, low CO2, high SVR, elevated filling pressure, think for acute MI, myocarditis, severe valve disease and arrhythmias. In volume loss, like hypovolemic shock, low CO, high SVR, low filling pressure, think hemorrhage, GI losses, burn, third spacing. Flow obstruction where obstructive shock, low CO, high SVR, obstructed feeling or outflow, think tamponade, massive PE and tension pneumothorax. Distributive failure where the distributive shock like high or normal CO, low SVR, think sepsis, anaphylaxis, neurogenic injury or adrenal crisis. Treatment of shock follows hierarchy where simultaneous approach, stabilize first then tailor the therapy to the specific etiology, golden rule, restore perfusion quickly while investigating the cause. First, we should see for the airway breathing and circulation where the airway and oxygenation, secure airway GCS less than 8, provide supplemental oxygen, consider early intubation, mechanical ventilation, reduce work of breathing and improve oxygen delivery. Vascular access and monitoring, two bore IV lines, arterial line for beat to beat BP, Foley's catheter for urine output, continuous ECG monitoring should be seen. Volume resuscitation where crystalloid bolus is used in most types of shock, guided response assessment is seen. Exception in cardiogenic shock, cautious fluid challenge only. Vasopressors and inotropes are used, noradrenaline, first-line drug for distributive shock. Dobutamine is used in cardiogenic shock with low output, tailored to the hemodynamic profile. Cause to specific therapy where the antibiotics within the 1 hour of sepsis, pericardiocentesis for tamponade, thrombolysis or embolectomy for massive PE, revascularization for acute MI. Mnemonics for the today's shock has shock, categorize, resuscitate and target. In distributive shock, SANE, SANE. Sepsis, early antibiotics control fluids and noradrenaline. Anaphylaxis, where intramuscular adrenaline, antihistaminic, steroids, neurogenic vasopressors, atropine, spinal immobilization, endocrine hydrocortisone or thyroxine. In cardiogenic shock, MAM, MAM, MI, revascularization by PCI percutaneous angiography or the coronary angiography bypass grafting, inotropes, arrhythmias, mechanical where the emergency surgeries can be done. In obstructive, we have PPT, tension, pneumothorax where immediate needle decompression and chest tube, a pulmonary effusion, thrombolysis, embolectomy and anticoagulation, tamponade like pericardiocentesis or pericardial window. In hypovolemic shock, we have HGB, hemorrhage, GI blood loss and burns. Final takeaway from today's video is category match the physiology, initiate rapid resuscitation, deploy the targeted therapy to stop ongoing tissue injury and time is the tissue. Early diagnosis can help to cure the shock. Thanks for watching. If you have understood today's video, don't forget to like, share and subscribe.